All right, so I'm going to talk about nutrition and the gastroenterologist, improving patient outcomes with nutritional assessment and therapy in inflammatory bowel disease. And I must first give a disclosure in the sense that, you know, anytime somebody gives a major talk, they always change their slides. So my slides are a little different from the handout you have, but not much difference, just a little bit of changes in the order and just a typo or two that I fixed. Okay. So, 25% of all cases of inflammatory bowel disease are actually diagnosed in childhood or adolescence. And pancolitis is often a common presentation in pediatrics. Patients may have abdominal pain, diarrhea, rectal bleeding, and weight loss. And what's unique to the pediatric population is that we see growth failure. So this schematic simply shows the multifactorial aspects of growth. All of these different aspects go into growth. Nutrition, as you can imagine, so how many calories you take in, if you're malabsorbing calories, or if you have increased caloric demands. The growth hormone axis also plays a significant role in growth. Steroids, which may negatively impact your bone health and also your growth and your sex steroid production. And cytokines, which can lead to anorexia and also negatively impact bone mineral density. So throughout the talk, we'll first start with talking about growth failure. We'll talk about delayed puberty, low bone mineral density, anemia, and micronutrient deficiencies. And we'll go through each and every one of these micronutrient deficiencies with 5 slides. So by the time you're finished, you guys will be geniuses with this. So first, we'll talk about growth failure. So, as you guys might imagine, it's easy to pick which one of these siblings actually was diagnosed with Crohn's disease. And I remember being struck by this picture as a resident at Cincinnati Children's when Dr. Mike Farrell showed this picture of his patients when he was giving a talk about growth. And as you can see, these are actual fraternal twins, but they're both 16 years old. And you can see that the patient that is affected with Crohn's disease is significantly stunted as compared to his twin brother. This is actually the growth chart on this patient, and as you can see, at about 9.5 years of age is when this patient really started falling off of his growth percentiles or showing evidence of growth failure. So how do you define growth failure? So it can be height less than the 5th percentile, a decrease in height velocity below the 5th percentile, or the child simply falling off their own personal growth curve. You're much more likely to see it at diagnosis in patients with Crohn's disease as compared to those patients who have ulcerative colitis. And it can result from inadequate caloric intake. They may have gastritis, esophagitis, and they have fear of worsening symptoms, so they may not eat as much as they should in order to gain weight. As you can imagine, they have malabsorption from especially the small bowel disease, and they may have increased energy expenditure from chronic inflammation. So these pro-inflammatory cytokines that I kind of mentioned before have a direct effect with anorexia, with the desire to eat. You may see decreases in IGF levels, which produce a growth hormone resistance in patients with inflammatory bowel disease. They're not growth hormone deficient, they're resistant. And also exogenous steroids have a negative impact on growth. So cytokine levels are found to be increased in malnourished IBD patients, and they induce specific metabolic changes, including stimulating muscle breakdown. Now, in animal models, repeated injections of cytokines can lead to anorexia, and metabolic changes can be counteracted by blocking these cytokines. The pro-inflammatory cytokines that have been linked to this have been TNF-alpha, IL-1, and IL-6. So this schematic simply shows the growth hormone axis, in which gonadotropin releasing hormone and somatostatin play an impact on their feedback loop. So growth hormone is produced, and it can have a direct effect on the liver. The liver produces IGF-1, an increased expression. So IGF-1 goes on to affect cartilage, bone, and soft tissues. Growth hormone by itself can affect adipose tissue and muscles. So in the setting of inflammatory bowel disease, you're going to see decreased IGF-1 levels. Having said that, you don't see growth hormone deficiency. So it's actually more of a resistance per se than a deficiency in these patients. So who's at risk to develop growth failure? Boys have been found consistently to be more at risk. One study done by the group at UCSF looked at about 1,000 patients that they followed within the IBD consortium, and approximately 10% cumulative incidence at 10 years from the time of diagnosis. Those patients are at risk to develop growth failure. When Dr. Santango, who's at University of Chicago, looked at males with Crohn's disease, he found that they were significantly shorter than control subjects, regardless of their Tanner staging. And if you adjust the height Z-score using mid-parental height, it was still below predicted. When the group at UCSF again looked at patients who were at risk to develop or need surgery, the patients with poor growth were twice as likely to undergo surgery. So growth failure in patients with inflammatory bowel disease has significant impact on adult height with potential need for surgery, and also in puberty delay, which I'll talk about a little bit more. So this is a study that looked at about 300 patients who had inflammatory bowel disease that were followed at Boston Children's, and they measured the heights of the parents in addition to the patients. And they found that the parents of the growth impaired group had lower mean height Z-scores as compared to the non-growth impaired patients. Of the 108 patients in which they had final heights, the growth impaired group had lower adult Z-scores as those patients who were not growth impaired to begin with. And about 11% were persistently growth impaired as adults. So lower parental height and minimum patient height Z-score were significant predictors of lower final adult height. The group at Sick Kids, when they looked at their cohort of patients, their IBD kids who were less than the third percentile, 59% of those patients actually failed to reach the third percentile for adult height. So inflammatory bowel disease definitely can have a negative impact on final adult height. So again, we see our patient on this side as compared to a sibling, and this is after the patients are adults, around 21 years of age. And clearly you can see, despite the fact he had some catch-up growth with his fraternal twin, with his sibling, he still was permanently stunted and did not have reached his full potential with regard to height. And again, this is the growth curve that showed this patient around 9 years when he was diagnosed, or when this first started, and then when his treatment started at 16. And you do see there's an increase that he's starting to fall along a growth curve. But again, he's permanently stunted because of his prolonged lack of therapy. So how do you assess growth in these patients? Well, height and weight measurements by trained staff at each visit. Obtaining premorbid height and weight at baseline is very important. Obtain parental heights and calculate mid-parental heights and percentiles. And evaluate height velocity at 4 to 6 month intervals in clinic. So what about the impact or the nutritional complications resulting in delayed puberty? So this schematic actually demonstrate what normally happens with gonadotropin releasing hormone. It's released by the hypothalamus, leading to production of LH and FSH by the anterior pituitary glands, which has an effect on the ovaries, leading to progesterone and estradiol production, and in the testes, testosterone production. In patients who have inflammatory bowel disease, for example, the boys may be testosterone deficient, and I'll talk a little later about one study that actually treated boys with testosterone as a result of their deficiency. Females may have a later onset of menses in addition to their puberty delay given their growth hormone resistance. So the mean age mean age of onset of puberty is about 11 years in girls and 12 years in boys. Delayed puberty in girls is considered about 13 years and 14 and a half years in boys. And again, you're more likely to see delayed puberty in patients with Crohn's disease as compared to those patients with ulcerative colitis. One study that looked at a Dutch cohort found a delay in puberty as compared to controls of by 0.7 years and 1.5 years in the Crohn's disease patients in the US. So this retrospective cohort looked at patients with inflammatory bowel disease, and again, the Crohn's patients were more likely to have delay, and the boys were more significantly affected. Testosterone was used in the same cohort of patients, and they had 8 boys with a median age of 14. So 7 boys advanced in their Tanner staging, a puberty stage, and 6 had greater than a 50% increase in height velocity. Again, this is a smaller study, retrospective, a total of 8 patients, but it does suggest that perhaps testosterone treatment in certain patients may be advantageous to enhance puberty. What about cytokines and its effect on puberty? Well, TNF-alpha, again, IL-6 and IL-1, as I mentioned before, affect or induce anorexia and can lead to a decrease in sex hormone function with testosterone and in girls with synthesis of sex steroids in the ovary. So this study that was published late last year actually looked at the influence of IGF-1 in patients with inflammatory bowel disease. And we know that sex hormones influence pubertal growth via the growth hormone axis and IGF-1. And it's very important for statural growth. She looked at females that were less than 15 years of age and males less than 17 in her cohort of about 90 patients. And she found that the IGF-1 levels were decreased in males along all Tanner staging. And inflammatory markers were a significant predictor of low IGF levels, and the markers correlated with testosterone levels in males, but not in estradiol levels in females. So this suggests that inflammation on hormone levels may differ by gender. So what effect does corticosteroids have on growth? Again, they can decrease effects of growth hormone and IGF-1 at target tissue, leading to inhibition of bone growth, inhibiting collagen synthesis, and decreasing sex steroid secretion. So typically, the medical management for patients with Crohn's disease, which I'm sure everybody's quite familiar with, is to control the inflammation. And to try and do this by limiting steroid exposure. As I talked about before, steroid can have some significant side effects to growth and Tanner development in patients. So we commonly use 6-MP or azathioprine, or in some instances, infliximab is necessary. Aggressive nutritional therapy is also something that's probably not used as much in the United States as is used in the UK, but supplementation, whether it's oral or NG or even G-tube, and it's debatable whether elemental versus a polymeric formula actually makes a significant difference in enhancing remission in these patients. In patients who have significant delay, perhaps before they're requiring a surgery or surgical intervention, TPN is also a potential therapy for these patients. So what about bone mineral density in these patients? So you can define osteopenia, or a mild decrease in bone mineral density, if those patients have Z-scores of less than -1. You don't really see osteoporosis, quote unquote, in pediatric population, but you can probably refer to it more as a moderate to severe decrease in bone mineral density. And that's defined as a Z-score less than -2. The peak bone mass in boys is 18 to 20 years, and in girls is 16 years. So if the age of diagnosis in this one cohort of IBD patients was 10 plus or minus 4 years. So as you can see, that's a long time for those patients to perhaps have uncontrolled inflammation that can eventually negatively impact their peak bone mass. So what's the etiology of the lower bone mineral density? Well, you can have decreased calcium intake. As you can imagine, you have calcium malabsorption. as usual therapy in the United States, steroids are going to lead to a reduction in calcium absorption. You may have stimulation of osteoclasts. You may inhibit osteoblasts and downregulate gene expression of calcium-binding proteins. Cytokines, like I mentioned before, may result in bone resorption, and also you can see lower vitamin D levels in these patients. So bone mineral density is heavily influenced by growth and also for puberty. So you may have to correct for their age, their bone age, or their BMI. Most people probably use or are used to using DEXA scans. Now, DEXA scans are two-dimensional, and they measure a ratio of the bone mineral content over the area measured and may lead to an underestimation of bone mineral density. Now, more and more people are using peripheral QCT. Does anybody have access to this at their institution? Yeah, not a lot of people actually have access to it. So it's more of a 3D assessment of the structural and geometric properties of the skeleton, and it measures the muscle cross-sectional area, and it's a surrogate for total muscle mass. But as you can see, there are not a lot of people who actually have access to it, to use it. So DEXA is probably still the main standard of care for these patients to assess bone mineral density. Well, what about the prevalence of this problem? You look at the group at Connecticut. They looked at their patients and found that 43% or 58 patients with Crohn's disease had osteopenia as compared to 39% of UC patients. And they actually had a fairly high number of their controls, 29%, who had low bone mineral density. If you look at a prior paper that looked at patients that were followed here in Chicago, Gokhale saw 35% of Crohn's patients had osteopenia as compared to 22% of patients with UC. When you looked at moderate to severe bone mineral density, 12% of the Crohn's patients versus 6% and 2% of controls in the Connecticut group versus 18% and 3% of the UC patients. So essentially, Crohn's disease also predisposes patients to have low bone mineral density for a multitude of reasons, including uncontrolled inflammation, calcium malabsorption, low calcium intake, and perhaps growth hormone resistance. So this study looked at a cohort of patients over a 2-year time period, and it looked at their total body BMD score. So as you can see, although the patients with Crohn's disease were minus 0.78 for their mean, 0.46 for the UC patients, and negative 0.17 for those control patients. In the Crohn's disease group, a bone mineral density Z-score of less than -1 was associated with a lower BMI and a higher interleukin-6 level, which I mentioned before is one of those pro-inflammatory cytokines that can have negative effects on anorexia and also clearly bone mineral density. So activation of bone formation paralleled clinical improvement, but the amount of bone mineral content gain was less than really was expected over the 2-year study period, especially again in those patients with Crohn's disease. In this cohort of patients, prednisone use did not seem to correlate with lower bone mineral density. So this is studies that used a newer technology and looked at the forearm of 143 IBD patients, with 98 patients having Crohn's disease and 29% being newly diagnosed. So height, weight, and muscle mass were lower as compared to the age and sex-matched controls. And they actually found that serum albumin was a good marker for muscle wasting and abnormal bone development. So decreased mechanical stress may relate to reduce bone mineral density, and the authors suggest that improving lean tissue mass via nutritional support or by increasing weight-bearing activities may improve bone mineral density. So vitamin D. It's produced by the skin when exposed to UV radiation, and it's the most abundant, 25-hydroxy-D is the most abundant metabolite, and it's indicative of overall vitamin D status. How many people regularly check the vitamin D levels of their patients? Vitamin D, okay. Do you know your own vitamin D levels? How many people raised their hand then? Okay, were they good? Good, okay. Mine was 10, so. So PAPA looked at her IBD patients, about 500 kids, and found about almost 60% had suboptimal levels, so they were less than 32. 14% were less than 20, which meets the definition of insufficient, and about 6% had less than 15 or were deficient. So as you can see, it's a significant issue in those patients who have inflammatory bowel disease. What were the risk factors that they found? Most commonly, people with darker skin, winter seasons, patients who may live closer to the northern latitudes where the sun's not hitting directly, lack of vitamin D supplementation also affect vitamin D status. SED rate, or ESR, as a marker of intestinal inflammation in this cohort was associated with lower vitamin D levels. They theorized that maybe it was related to malabsorption or losses of protein-bound 25-hydroxy-D. So the recommendations have been that children with Crohn's disease and ulcerative colitis should really be screened for vitamin D deficiency. Most patients are recommended, especially the adolescents, to get about 1,300 milligrams a day of calcium, and vitamin D 400 to 800 international units. And that really depends on how low they are at the time of your diagnosis, if they need significant repletion to start off with. So I think for adult patients, we frequently talk about, or you think about the older woman who has menopause and lower bone mineral density, and we frequently talk about fractures. We have some evidence in the pediatric population about fractures in IBD, but we don't have the large 15,000, 20,000 randomized controlled trials with patients to give you a good estimate of what exactly the risk is for these patients to develop bone disease, or rather to develop fractures. This 1-2-year prospective study found a twofold increase in fracture risk with each standard deviation decrease in areal bone mineral density. But there have been no real prospective studies between fractures and bone mineral density in pediatric IBD patients. This one study from 1997 actually reported 5 patients with Crohn's disease who had a lumbar spine bone density ranging from -2 to -5, and they all had vertebral fractures. Anemia. Blood loss. You can result from chronic inflammation. You may see it in micronutrient deficiency. Those patients may be B12 deficient because they have significant ileal disease. You may have folate deficiency because of other medications that they're taking, such as sulfasalazine, methotrexate, and iron, which you may have impaired utilization, or you may have malabsorption. You can see myelosuppression in a number of these drugs, but you think about it, 2 and 6-MP, and also hemolysis. So it's a large number of factors that can go into anemia in patients with inflammatory bowel disease. So how do you diagnose it? How do you figure out what the etiology is? Well, is it microcytosis, macrocytosis, or is it normocytic? Do you have a low serum iron? Do you have a lower ferritin? Now, ferritin is somewhat tricky in that, as you know, it's an acute phase reactant. So it may be falsely elevated in the setting of inflammation. So it may give you a false sense that this patient is not iron deficient when they actually are. More and more, I've seen soluble transferrin receptor levels used. The hematologists actually recommend using those to help differentiate with iron deficiency anemia. You can look at serum folate levels, serum B12 levels, which are not necessarily indicative, but you can also use methylmalonic acid, which is a precursor of B12. You can do urine, or you can do serum to give you a clue whether or not, because it's before B12 in the pathway. So if the levels are high, you're the patient's at risk to have B12 deficiency. And so it's a more reliable marker than using just a serum B12 level. So there are a variety of vitamin and micronutrient deficiencies that have been described in inflammatory bowel disease, including zinc, folate, B12, vitamins A, C, D, and E, beta-carotene, selenium, copper, and iron. And I'm not going through all of them, but I'll talk about I talked about vitamin D already. We discussed iron. We'll talk about zinc. So zinc is a cofactor in more than 300 metalloenzymes, and it plays a role in RNA and DNA synthesis. lymphocyte proliferation, cytokine production, and free radical activity, and wound healing. Serum levels don't reflect total body zinc depletion, and the levels really depend on albumin binding, with greater than 95% being intracellular. There are no large control studies to actually determine the value of zinc repletion in patients with inflammatory bowel disease. What about folate? Well, folate can impact synthesis, methylation, and repair of DNA. And at the time of diagnosis, this one study from Mel Hyman's group at UCSF actually found higher folate levels in newly diagnosed inflammatory bowel disease patients. But the problem is, over time, the medications are going to start to interfere with folate metabolism. Sulfasalazine, methotrexate, and it's usually recommended when patients are receiving these drugs that they get 1 milligram of empiric therapy. Now, there's some concerns more recently that the risk of colon cancer and other tumors may be increased with folate supplementation. Low folate has its own negative side effects. It's thought to affect homocysteine levels, which may increase the risk of thromboembolic events in patients with IBD, although again, there are no large studies to prove that, but that is a theoretical risk. Fish oil. Anybody have patients that you prescribe fish oil, or they just came in on fish oil? A lot of people have been using fish oil. So as you can see by this cartoon, I think more and more people are thinking fish oil, at least when it first came out, was very important, and that it would actually be of significant benefit. And you can see the large horse tablets of fish oil on the other side. So, omega-3 polyunsaturated fatty acids have been shown to have positive effects in a variety of diseases. So cardiovascular, immunologic, inflammatory, and the benefits are secondary to anti-inflammatory, vasodilatory, and hypolipidemic properties. And it's thought to have regulatory effects on cell death and growth, and have some anti-cancer effects. It's incorporated into the wall of cells involved in inflammation, and it's thought to reduce the production of inflammatory properties, halting the inflammatory cascade. Vegetables have some omega-3s present, but fish oil is actually the largest source of this product. So the biologic rationale for their use, there were some animal models with IBD and tissue samples from patients with IBD that demonstrated strong anti-inflammatory benefits with the use of omega-3, but the clinical trials have showed limited or absent clinical benefit. And there are significant limitations: poor absorption, inadequate dosing, inadequate delivery system. There's really no data to support their usage in inflammatory bowel disease of any large controlled trials. There's also some pitfalls of potentially using fish oil in these patients. The FDA doesn't regulate it, so you can have mercury and other toxin contamination in fish oil. You need to have a reliable supplier that you know that you're having non-contaminated product. You can have some side effects from it: nausea, vomiting, diarrhea, an unpleasant taste, bad breath. It's less common with the time-released preparations, and you may actually need to take 6 to 12 capsules a day for any potential benefit. And so you remember I showed you how large those capsules are. It's going to be a little hard to get the 11-year-old to swallow 12 capsules of fish oil when you can barely get them to take their Asacol. So now we'll talk about enteral nutrition. And so these are a number of the enteral nutrition products that we have on the market. We have EO Splash, Pediasure Boost, Peptamen Jr., Pediasure Peptide, Elokel Jr., and Neocate. So this algorithm was actually taken from a review or position statement from the UK equivalent of NASPGHAN, and it's their algorithm for the therapy of Crohn's disease. So they induce remission by either treating with steroids or, more commonly, an exclusive enteral liquid diet for about 6 weeks. Anybody here ever used an enteral diet? How many people? Okay. Success? No success? Success? Okay, good. Let's see. When the survey was actually done, only 4%, and it's probably all the 4% here, of North American PGI use enteral nutrition regularly versus 62% of our European counterparts. It's really not clear the exact mechanism of action for enteral nutrition. Is it elimination of dietary antigens that's playing a role? If you're just overall leading to nutritional repletion, if you're changing intestinal permeability, decreasing synthesis of inflammatory mediators because you're changing reduction of dietary fat, or are you providing important nutrients to the diseased intestine? And there's some evidence that it affects gut flora and that it's anti-inflammatory in nature. So depending on what study you look at, there's been anywhere from 20 to 85% remission of Crohn's disease in newly diagnosed patients. This one meta-analysis looked at 144 patients and found no significant difference in remission rates at 8 to 10 weeks of therapy with enteral nutrition as compared to steroids. Admittedly, this is predominantly a study that had more adult patients in it. The second Cochrane review actually showed an odds ratio of 0.33 favoring the use of steroids in patients. Again, predominantly adult patients, and the pediatric studies were really excluded because of methodology. So the patients in this cohort that received partial enteral nutrition as compared to those who received full enteral nutrition. So partial meant they ate a regular diet during the day and they were drip fed at night. So the people who were receiving total enteral nutrition through an NG, through oral liquid diet had a remission of 42% versus 15% of patients who were on partial. So who are candidates to actually receive enteral nutrition? Well, it's thought that it's more successful in patients who have some small bowel disease. If you look at this one study of pediatric patients, 11 out of 12 patients who had ileal disease went into remission. 32 of the 39 who had ileocolonic disease, and half of those patients who had colonic disease. A larger meta-analysis could not, because it wasn't powered properly, could not find enough significant difference between the sites. So I think for most people it's acceptable to try in any patient with Crohn's disease, but the concern is the patients who have isolated colon disease may not fare as well as those with small bowel disease. Now, when you're deciding to treat a patient with enteral nutrition, you also need to be concerned about refeeding syndrome, especially those patients whose BMIs may be less than -1.5. So what's refeeding syndrome? They can have fluid shifts, electrolyte abnormalities, including low potassium, phosphate, magnesium. And it usually happens when a patient is starting on enteral nutrition after being malnourished for so long. And so those patients that you believe that are at risk with low BMIs should be hospitalized and monitored with daily electrolytes and repleted as needed, and have a gradual refeeding, okay? So you can't advance their feeds to full feeds within 24 hours, or you're gonna have complications from that. So gradually increasing their feedings over the course of 3 to 5, 7 days to get them to their goal feedings, monitoring their levels and adjusting, supplementing accordingly. So you made the decision, you're going to treat your patient with enteral nutrition. So your decision now, which formula am I going to use? Some people use elemental formulas. You can use a semi-elemental formula, or you can use a regular, a polymeric formula. So there's some advantages to probably using a polymeric formula as compared to the others. One, has anybody tasted some of these other formulas? Yeah. So most people probably would prefer something that has more of a polymeric formula because some of the other formulas are just not as palatable. They also tend to be less expensive, and perhaps you can avoid using an NG tube. If you have a really dedicated, perhaps an adolescent kid, you can get them to drink this formula and be compliant with the diet. There's some question whether or not there's more weight gain than using an elemental formula. There's also some suggestions from some other studies that perhaps elemental formulas are better because they have a higher glutamine content, but there's really no firm data suggesting that one formula is better than the other at this point. And also you have to figure out, is this a patient that's going to be NG or PO? Is this an adolescent kid that can put their tube in and out, or is this a mother who's going to have to put this tube in there and hold the kid down every time the tube comes out? So all of this will come into play when you're making your decision about what formula to pick and which route to do it, if you're even able to initiate it. So Growth and mucosal healing is often an endpoint when we look at therapies for inflammatory bowel disease, and it's really variable depending on the study. So height velocity standard deviation scores were significantly increased in this one study when they looked at patients compared to those who received steroids at 6 months after therapy. The same group found a 79% remission rate in those children receiving a polymeric diet with supplemental TGF-beta. They found histologic improvement in 8 cases with small bowel and 2 in the colon. Now, they saw no mucosal healing in those patients that had received steroids. And it's really not clear what the impact of mucosal healing will do long term. In theory, potentially you should have better growth if you have mucosal healing in these patients. Again, no large studies to support that. So you picked your formula, you know what route you're gonna do. Now the question is, how long do you do it for? So looking at these 2 papers, which again is the UK equivalent to NASPGHAN and the NASPGHAN position statement, physicians or peds GI have used it anywhere from 3 to 12 weeks, with the mean being about 9 weeks. And 81%, or the majority of people, actually picking somewhere in between 6 to 8 weeks for therapy. You can see improvement in inflammatory markers within a week. However, remission may take 11 days to up to 2.5 weeks. And at least 3 to 4 weeks is the current recommendation for the length of trial. So even if the patient's not getting better 2 weeks into it, continue on to make sure that you've given it a fair trial before you discontinue it. So your patient's better, they're in remission. At some point, they're gonna wanna eat again. So this is the subject of much debate. How do you reintroduce the diet? In the UK, they reintroduced the diet very cautiously during the course of 1 to 3 weeks. In the United States, the guidelines state to introduce a meal every 2 to 3 days, and that appears to be a reasonable strategy. So essentially, nobody has a straight way that they actually do it. So enteral nutrition has been used as monotherapy, as we see done in the UK, or in combination with other standard medications, including 6-MP, infliximab, and mesalamine. The Hospital for Sick Children, they looked at their cohort of patients, and 47 patients, or 72% of their patients with Crohn's disease, actually went into remission. Of those 47 patients who persisted with the diet, 28 children continued with their NG feedings despite having a regular diet during the day. 19 patients discontinued their drip feedings. You saw a 43% versus a 60% relapse at 1 year. So those even receiving supplemental feedings at night seem to lend to a more positive outcome for those patients compared to those patients who just stopped the feedings. So enteral therapy offers an alternative to steroids in patients with Crohn's. It has potential to improve growth and height velocity, and the hope is that you can avoid some of the side effects of steroids. However, we need further research to determine the exact mechanism and the exact regimen in order to continue. So in conclusion, growth failure and puberty delay are multifactorial in etiology. Close monitoring of vitamin levels, growth, and height velocity are necessary. Low bone density and fractures can occur in inflammatory bowel disease patients. And enteral nutrition is a potential therapy of treatment in Crohn's disease.